Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium. And I have with me today Dr. Meghan Gannon, a family physician with All Access Medicine in Maury Regional Medical Group in Spring Hill, Tennessee. And I have to tell you, I'm very excited that she's going to share with you what she presented at the Direct Primary Care National Summit 2017 in Washington, D.C. a few weeks ago. To my knowledge, and the FMEC has been involved with the national summit since we held the first one in 2013. To my knowledge, she is the first family physician who presented at one of our summits who has figured out how to work with a hospital so that we have a model direct primary care practice that's sponsored and supported by a hospital. And she's going to tell us how this works and how she managed to pull this off. So Dr. Gannon, thank you very much for joining with us, and I'm going to turn over control of the webinar to you.
Thank you very much for having me. It was a pleasure to speak at the summit and even more of a pleasure to record this for others to share. So let's get started. So the title of my talk is "The Hospital is Not the Enemy." I didn't realize how much of an anomaly my situation was until I was at the Direct Primary Care Summit, and I started talking with people and their negative interactions with hospitals in their state and in their area. My hospital is Maury Regional Hospital. They have been very supportive of me since the beginning. I was fee-for-service for 8 years, and then they approached me to open up my own direct primary care office a year and a half ago. Here are learning objectives. So the perception of the hospital is that they're a big corporation who has a healthcare monopoly with big business as their main focus, eating and churning out doctors as they go, and while they're getting rich in the meantime, we're all suffering. The perception of the doctor who's in fee-for-service is that they're exhausted, worn out, simply can't go anymore. The doctor will see you now, Miss Perkins. Please try not to upset him. They don't know what to do, and they really have no money because they're just working themselves to the bone. It doesn't really have to be that way. At the summit, I had people raise hands to see how likely they were to approach their local hospital to assist in opening or supporting their direct primary care practice. Clearly, most people said that they were unlikely to approach their hospital because they just didn't think it was a possibility. This is a chart of work-life balance jobs that exist currently. It's from a magazine, and if you can see, there's not a single medical job listed on this list. We simply don't have work-life balance in the normal fee-for-service arena. But that doesn't have to be the case. Your perception doesn't have to be the reality with a hospital-sponsored direct primary care practice and direct primary care in general. You can have balance of work-life as well as financial resources. You can further your career. You can have a family and friends, pay back your student loans, all while having the umbrella of the hospital supporting you in your venture. So the biggest obstacle holding you back from starting your own direct primary care practice, again, this was another question I posed to the attendees of the meeting. Jumping into the unknown is very scary for many people. Not having a fallback plan, startup costs and being poor in the meantime, lack of consistent salary, and fear of losing patient relationships are all significant concerns with opening up your own direct primary care practice. So why should you pursue hospital sponsorship? Well, the thing is, many people think about doing direct primary care for a long time. Study in the Direct Primary Care Journal showed that 30% of people were looking at it for 12 months or longer before they even did anything. And if they were to transition, how long would it take before they anticipate moving forward? Majority of people, at least 3 to 6 months, but a lot of people even longer than that. They're just simply waiting and waiting and waiting. The majority of people who go into direct primary care wait until they've been in practice 10 to 15 years. Now, why is that? Well, they're busy, they've established a practice, they feel secure, they don't want to rock the boat, they don't want to lose their salary, and so they wait. Well, those people who are already practicing for 10 to 15 years probably have another 10 years left, whereas the group of doctors who are younger will have much more time to be satisfied with their job performance and their home life if we could simply get them to switch over to DPC early. The challenge is they don't have the nest egg and the resources that they've built up to feel comfortable doing that always. So why wait? This is the reason why I didn't wait. I have 2 young boys and a husband whom I adore, and working my fee-for-service job, I was very successful. I had 4,000 patient panel. I was booked out for 3.5 months before anyone could have an appointment, and that's considered success in medicine. Well, I don't really consider that success when you can't successfully take care of patients. You're exhausted, running yourself ragged, and you never see your family. So with hospital sponsorship, my hospital came to me and offered to open me up this practice, which I understand is very forward-thinking, and I really appreciate them for that. It offered me the chance for financial security. I don't moonlight. 82% of physicians, direct primary care physicians, were moonlighting to make ends meet in 2016. I received my paycheck from day one. I didn't have to go into the poorhouse or take out loans to open up my practice. I am the breadwinner for my family, and I am not a risk taker by any means in the traditional sense. So for me, this is something I've looked at. My husband actually brought up the general scope of concierge medicine to me when I first graduated from residency, but there was no way I could make that work without a stable backing. The mean salary, so this came from the DPC Journal. So direct primary care doctors opening up in their first year, 17% of people made under $100,000. I mean, that's still a fine salary, but to go from probably what you're being paid at fee-for-service down to under $100,000 for me would be challenging to keep with the lifestyle that I had acquired after 8 years of fee-for-service. A lot of people, 12%, said their salary increased, which means most of them decreased during that same time frame. So with my hospital, I was very fortunate. They let me do everything from the ground up. One thing that I hear from naysayers is that I lose autonomy by joining the hospital. Well, not if you have the right hospital helping you. Literally, these are the plans that I drew up. I had to try to guess how big a handicapped bathroom needed to be because I was literally trying to figure out how we wanted our office to look and what we wanted to do. And they gave me free rein to do it all within some reason. But I did everything from checking the construction site as it's ongoing, making adjustments. My kids helped. I mean, it was definitely a family affair. Even though I don't own the building, it was still mine. And we ended up with a really beautiful, nice result because of it from their financial security and their backing. On average, hospitals spend about $200,000 starting up a practice. That's kind of what they commit to starting a practice for anyone. And I don't have an extra $200,000 to start my own practice. Now, of course, it doesn't have to be that way. People can do things for much less expensive, and it will still function and be nice. But I was very lucky to have all of that backing to be able to do it the way we wanted to do it. Another big issue people have is when you switch from your fee-for-service and maybe hospital-employed practice to your own practice, they won't tell anyone where you went. You disappeared in terms as it's seen to everybody else. Well, with my hospital, they promoted my practice and promoted my transition. They covered the associated costs with mailers to all of my patients. We sent out 3 different sets of mailers. There's no harsh feelings with the hospital. There's no burned bridges with my partners. That's a big thing for me, my former partners, because they still help me to this day. We had a town hall meeting where because the hospital is associated in the town and very strong donators in the town, we had donations back to us. Gigi's Cupcakes was super nice to donate cupcakes, and yes, I realize the irony in treating diabetics and having cupcakes, but you do what it takes to have them come. We had a wonderful town hall. We have the Chamber of Commerce come out and join us. So standing next to me to my left, so I'm in the blue, standing next to me to my left is the CEO of the Murray Regional Hospital. Next to him is my regional director. Next to him is another regional director. On my right is the CEO, is my nurse, Christy. Next to her is my CEO of my Murray Regional Medical Group. So everyone was there proud to support our opening, and it's just incredible. Also, administrative assistance. This is a big thing. We're on the Direct Primary Care Facebook page, and there's all the time questions about how do I do this? How do I opt out of this? What about CLIA waived forms, CLIA waived testing? How do I do PICOS? Who has malpractice insurance? What do you use? I didn't have to worry about any of that stuff. Some of the administrative stuff the hospital just took care of because that is what they do. They do it day in, day out. They have people for it. So I signed some papers to opt out of insurance panels, and it was all taken care of for me. My taxes, benefits, accounting, all of those things, I can call someone and ask for help. The really huge thing is for my nurse, Christy. So I still maintain my same employee benefits with my 401k, my hospital insurance, but also my nurse still. It was an incentive for her to move over here. It's a lot of extra work, but she maintains all of her same benefits she had from the hospital, things that there is no way I could ever provide her if I was doing this on my own. She still has paid time off. She has her health insurance, prescription insurance, all of those things. The other thing we have is she gets to go on vacation, and I'm not in the lurch. We have a float pool of nurses, and actually one of my former nurses who used to work with me in fee-for-service is in the float pool, and so she floats up here whenever Christy goes on vacation. That saves Christy's sanity, which therefore saves my sanity, and everybody's happy if Christy's happy. I also get doctor coverage for myself. So my fee-for-service former partners, I trade with them. So I take phone calls for them once every 4 weeks for a week at a time, and they cover me on vacation when I'm out. Now, they don't hardly get any phone calls, but they're willing to do it. My regional director, Nathan, he has been an immense help. He is my person that I go to for help with anything. Recently, we had a plumbing issue, and we're closed on Tuesdays, so I'm with my son. He met the plumber here on Tuesday to get it fixed. I didn't have to fret and worry about that. He handled all of it. It's a small example of what he does. I will tell you, I call him day and night, text him whether he's on vacation or at home, and he helps with anything that I request. Big thing with still being affiliated with the hospital is I have networking abilities. My lab affiliates, we were able to negotiate my lab rate significantly down because the hospital is a big user of this lab company. We initially had negotiated it down, and we were able to negotiate it even further by 40%, which was huge for my profit and loss statement. Corporate affiliate, same thing, EKG machines, purchase power from large group business. Connections to local business owners. So after I got home from the DPC Summit, the CEO of the hospital wrote me an email asking me to invite me to speak with the Kiwanis Club, and he wanted to introduce me to the Kiwanis Club of Columbia and ask me what dates might work for me. The hospital is very involved in the community, and they are wanting to share this brand extension with other people. Clearly, marketing is very helpful. There's some pluses and minuses about marketing with my hospital. I'll get to that in a minute. But media coverage, putting out media releases for the newspapers, ads, print ads, billboard ads, IT assistance. I mean, the list keeps going on. IT assistance, legal assistance, referral team if I need them for help if Christy's in the lurch. These are all resources that the hospital has that I have access to. So lab pricing, there's a really great business model and people in our community who will help you set up your own DPC practice. And they are wonderful in the fact that they have published what prices they pay for labs to help you negotiate your lab prices lower. Because I'll be honest with you, the first offer we had from our lab company didn't match what this other group was able to negotiate. So we were able to bring to the table what that other group had negotiated and said, we know you can do better. We know you can. And in fact, we were able to do better lower pricing than that other group by 40% on our CMP, 42% on our lipid panel, 36% on our PSA, and 47% on our hemoglobin A1C. When you draw volume labs, which clearly I pick and choose who needs labs and do it based on when they need it, but saving almost 50% compared to an already really good price is amazing. We were able to purchase our EKG machine for 31% discount, exam tables because the hospital bulk purchases. Now the the exam table is kind of a lie because I was in the clinic next to my old clinic, which they were changing over to a lab, and saw that they had exam tables sitting there that were going to be thrown away. So those are the ones we got. So ours were actually free. It was called, quote, redistribution of assets. And so we received all of our exam tables for free. But a small example are our exam gloves. When we purchased through Henry Schein, instead of it normally being a box of 100, our box is 200 for the same price of 100 because it's GPO pricing for the hospital. financial support. So I was actually able to go to the DPC Summit thanks to funds that my hospital gave me to go and supported me going. Licensing support, online subscriptions, all of these things are all little nitpicky things, but when you add up an up-to-date subscription, medical journals, Hippocrates, CME funds, I mean, that's thousands of dollars a year in additional benefits that I have from the hospital. So cost sharing. We purchased vaccines, our flu vaccines last year from my other office. And we were able to, first of all, purchase the vaccines for about 5% under the published rate. But then we were able to, I think initially took 26 vials from the other office. And then as we were reaching December, realized we were over by 10. We really didn't need 10 of these vials. So we were able to sell them back to my other practice at no cost. So I wasn't stuck with 14 vials of flu vaccine at the end of flu season and have to eat all that cost. Recently, one thing that comes up in direct primary care is trying to finagle people with HMOs and TRICARE and TennCare and things like that. Sorry, TennCare is Tennessee's Medicaid. But what's really nice is my former partners are still on the HMO and TRICARE panels. And so I've worked it out with their office that if I need a referral that I can't get because I'm no longer on those panels, I set the patient up to see a nurse practitioner in their office. After having laid everything out in the note, the nurse practitioner says, "Hi, nice to meet you. I understand that you need to see an ENT for this problem." Does the referral through their insurance, and it's done, and everything comes back to me. It's been really wonderful. I'm still in the network of the hospital, so I still have all the access to my friends who are gynecologists, my friend the urologist. And we're all in the same system. So I email my GYN friend and say, "Hey, can you look at this ultrasound and tell me what you want me to do before she needs to come see you?" That, A, helps the patient, saves cost because I know exactly what test she wants or doesn't want, and is convenient for the patient and makes it seamless. And also I can say, "Hey, I need some help. I need this person in next week," and we're all still members of the same team. So that concludes why I want the hospital to help me. What benefit is it for me? Well, there has to be something in it for the hospital. Otherwise, there's no reason why they would help you. So they're really focused on quality. So all the quality measures and all of that are super important to hospitals. That's how they're getting dinged. They're getting benefits, all of that sort of thing. So they're looking to find an alternative care model that provides high quality, high patient and physician satisfaction, decreasing overhead and FTE costs. We can decrease per DPC practice, decrease costs by 4 FTEs per physician compared to fee-for-service. The biggest cost the hospital has are FTEs and paying for those benefits I talked about. And so with direct primary care, by cutting out the insurance, this is the simplest way where they don't need billers. They don't need people to track down claims that are coming back. Literally, it's a cash practice. And so for the hospital, this is a huge benefit for them to be able to cut costs. So direct primary care fits perfectly for the transition from fee-for-service to quality from the hospital's mind. The hospital is looking to promote who they are and provide different access points to the hospital. My town in Spring Hill is about 10 miles north of Columbia, which is where Murray Regional Hospital is. My town has about 35,000 constituents, people who live here. And Murray really is trying to provide a regional presence of providing low-cost, high-quality care. So they have lots of different modalities. They have a concierge practice. They have many fee-for-service practices, and then mine is a direct primary care practice. And so by providing all three of these different modes, and they also have an urgent care as well as something called prime care, which sees the TennCare, the Medicaid patients exclusively. This allows them to branch out and provide different entry points for people of all different variety of insurance and incomes and all of that, and provides them the ability to show that they're trying to meet people where they need to be met. And also our office is able to give a more personal feel. You'll see in just a minute how we're able to do that. So this is data from from a huge study that shows that percentages of people who get to goal with traditional and patient-centered medical home versus hybrid versus DPC, DPC just simply does better. We have more time. We're able to focus on the patient, figure out why they're not taking their medications, figure out how we can get their medications affordable. We can take better care of them, which then reflects positively on the hospital. This is information, by the way, from Dr. Brian Forrest. This is a pilot program for my hospital, so I'm the first in the practice of Murray Regional to open up this kind of practice. But obviously, they are piloting it with my practice and then hoping to expand to other communities. It's an attractive model for the medical cost sharing community, so MediShare and other programs like that, which currently hold back on patients seeking care because of cost. This allows them to seek care and actually stay healthier. High deductibles are the norm now. Deductibles have increased by 67% since 2010. I mean, it's just absolutely astounding how many people have high deductibles. 95% of my patients have insurance, 60% of which have a high deductible. Well, with direct primary care, we don't touch that at all. And so they know that they need to access those patients. They would much rather help them find affordable health care than have to track them down through billing and collections and lose all that money. It just makes more sense to them. So again, they're recapturing the cash pay patient. Free market pricing. So my hospital, I went to them and I said, okay, I need the cost for colonoscopy. What can you do for me for colonoscopy? And so they came back to me and said, okay, well, that's a really great question. We need to be able to give you an answer, but we can't just give it just for you. We have to make it for everyone who asks. Well, there are online websites, and I don't know if you've seen these or not, but if you haven't, you should go look them up. MD Save, Healthcare Blue Book, Clear Health Costs, New Choice Health. What happens is it's kind of like Groupon, where you plug in your zip code and what you're looking for, so colonoscopy. And it pulls up Dr. Smith will do a colonoscopy at blank medical hospital. All-inclusive price is $1,800. And you purchase that coupon, and then you present it when you go for your appointment. So that is all-inclusive of the anesthesia, the biopsies, the procedure, the post-procedural care, everything. So the hospital, my hospital, is now pursuing free market pricing, which will then hopefully drive down costs and help people make good choices and actually know what they can afford to seek good health care and stay up on, for instance, their preventative maintenance things. So that benefits the hospital to put their name out there saying this is what we offer and how much we offer it for. Enhanced patient satisfaction ratings and patient experience. My other practice is on this list, as well as my current practice is on this list. So in the past quarter for fiscal year 17, if you can guess which one is mine for patient satisfaction, you'll probably be right. However, what's crazy is I was in the other practice last year working my tail off, and yet we were still receiving low patient satisfaction scores. It was mainly the wait time for an appointment, staff happiness, et cetera, and these were things that because we're killing ourselves seeing 25, 35 patients a day, you just simply can't fix. You can't fix it. Well, there is one way to fix it, and it's with direct primary care where you see 10 to 12 patients a day and you actually spend time with them and they feel like they have their doctor. I'm the same doctor as I was in that other clinic, but people now feel I still listen to people. I haven't changed except I just have more time, and it reflects in my patient satisfaction scores online, on Facebook, and everywhere. And in turn, that reflects on the hospital positively. When you Google some of our other ones, they're not so great because they're complaining about wait time and care and time spent with a physician. So this also helps the hospital perception to improve by having better patient satisfaction scores. It's very expensive to hire and fire a physician. They would much rather hire a good physician and retain that physician and keep them happy. Physician burnout is a real thing. I was approaching that after 8 years of only 8 years of practice, charting 4 hours every night from 9 p.m. to 1 a.m. with 2 little kids. And I'm a concert pianist, and I can type while I look at you. And yet I was still having to work that hard at night to get my charts done. So what they recognized is that family medicine physicians are very high risk for physician burnout. Causing burnout are things like too many hours at work, too much paperwork. I mean, I don't even know what's going on with MACRA. Thank God I don't even need to know anymore. But I can only imagine how much stress that's putting on more people who are doing a fee-for-service. So they noticed that they want to be able to retain their physicians and make us happy, and direct primary care was another way to do that. So it's not all unicorns and roses. Let's be real. There are some things that are downsides of working with the hospital. Bureaucratic decision-making can depend on your institution. So my institution is very generous, and literally I said in my office, okay, I want wallpaper. And they said, okay, fine. I said, I want a conference room to be able to have meetings with patients and teach them and bring in speakers and have a community. They said, sounds great. So, but I understand that not every hospital will give you the autonomy that way. So that definitely depends on your hospital. EMR choices. So my hospital wanted me to stay on the same EMR, which of course I mentioned before is a benefit to be able to speak with other physicians and message other physicians. However, it is much more costly than some of the free platforms out there, which are very viable and good. Institutional policies, we mostly obey those. I mean, I'm actually wearing jeans right now on Friday, but nobody really cares. They don't come up here. Autonomy is hospital dependent, and then marketing policies and limitations. So this has been one of my frustrating things. My hospital doesn't want me to have a Facebook page for the office because they would like to be in charge of what goes out with the hospital name on it. And I get that, but in this day and age, social media is so huge, and it's free marketing, and we would be stupid not to delve into that. So instead, I made my own Dr. Meghan Gannon Facebook page and kind of skirted the rule because it's not hospital related, but it's just mine. So I've kind of had to do a couple things like that to try to still get what I think we need to promote the practice, but still stay within their guidelines. So at the DPC Summit, I now asked people, all right, after this whole talk and all of these reasons why you might want to pursue hospital sponsorship and why they might want to help you, how likely are you now to approach your hospital to assist you in opening or supporting your direct primary care practice? Clearly, there were still some people who said, hell no, we won't go, and they were, against the man and wanting to open up their own practice so they didn't have to listen to anybody else. But there were certainly more hands at the end of our talk saying they would be considering, they would consider approaching their hospital more so. So just to summarize, why direct primary care in general? Well, your quality of life is amazing. You can chart from anywhere, including answering messages from a Halloween party. You can actually take vacations with your children and know your patients are going to be taken care of without a mountain of paperwork when you get back. You can go to the AFP meeting in Orlando and meet with friends and colleagues, and you get to actually spend time with your family. I mean, that's a huge thing, and be a better doctor. In the 13 months now that I've been open, I have diagnosed 4 metastatic lung cancers, a metastatic tonsillar cancer, and a lymphoma, all because I could listen to them. They will tell you what's wrong with them if you simply just have the time to listen. And I have the time now to listen to my patients, to listen to my husband, to listen to my kids and my family. My nurse, it's just the two of us in our building. She and I, for the most part, we do great. We are 2 women, so that is one thing. But it's just the 2 of us. I don't have to worry about 30 women working in my office and having 30 moods at 30 different seconds. We work really well together, and I take care of her, and she takes care of me. I mean, it's absolutely wonderful. My kids come by the office like they own it. I mean, they know exactly where Miss Christie hides her candy, and they just go in that drawer and get it. I get to pursue my medical passions again. I'm writing an article in a newspaper every month to educate patients. I get to speak at summits and get to do recordings like this to get the word out. I really enjoy teaching, and doing fee-for-service and running ragged, there was no chance that I would have to do that. And then pursuing your non-medical passions. I enjoy party planning and crafting and T-shirt making. That's a friend's kid, not mine. I only have 2 boys. But I learned how to make cookies this year and decorate cookies and do fun things because I have time to do that again. So that summarizes my talk on why the hospital is not the enemy. You are more than welcome to contact me. My email is on there as well as cell phone number. There's a DPC Docs Facebook group on Facebook, and it's absolutely wonderful. It's a wealth of knowledge, and we all just share information and help each other and encourage each other. That's it.
Dr. Gannon, that was an awesome presentation, and just as awesome as when I saw you present in person. I do have a couple questions for you if
Sure.
you have a little bit more time. So you, your patients are paying a monthly membership fee. Is that how they pay for your services?
Correct. So my monthly, I have a monthly membership fee, and then I also have a day of service charge.
Okay. And can you mention, I don't think there's anything illegal about you mentioning how much you charge people for their monthly membership fee. Are you comfortable with that?
Sure. So at my practice currently, my monthly membership fee for adults is $49 a month, and it's $20 per visit when they come. Children under 21 are $25 a month with an adult membership.
Great. And could you comment on contractual issues with the hospital? So one of the things that I've watched, I was a hospital administrator at one stage of my career and helped set up a primary care network for the hospital. And the whole issue about non-compete clauses and other legal issues, what are your, I'm quite sure you've worked these kind of things out and have a written contract, but could you comment on, your hospital seems to be a little unusual in terms of their openness and flexibility. Could you comment on some of those issues that affect physician contracts?
Well, so nothing really, I mean, it did change a little bit only because I crossed county lines when I moved 1 mile up the street from my old practice. And so in that respect, my non-compete had to change a little bit, but I negotiated it, whereas my non-compete was for Murray County before. Well, now I'm in Williamson County. So I made sure that there was just a mile radius, like a certain mile radius that my non-compete applied should I decide to leave my current practice. But the rest of it, really, there wasn't anything else to change. I mean, my contract did change because I was on an RVU model before, and clearly DPC is not RVU based because that's the opposite of what you're trying to do. So my compensation did change a little bit, and I have a bonus structure set in place based on memberships and patient satisfaction and things like that. We had to be a little bit creative to figure out how to do that, but
I would think so, yes. So that's great, and people can contact you if they need to get more granular with those issues.
Sure.
Could you share with me, so I've been in the healthcare industry for a long time. I've known a number of hospital administrators, and I'm really struck by the flexibility and the vision that's being shown by your hospital leadership. You've commented on that in a number of places in your presentation, but what is it about this group of people that they can see the value of being flexible and giving you more control, quite honestly, than most hospital employed docs have ever had? What is it about them?
Well, they're specifically Murray Regional Medical Group, which is a group of probably now, 65 physicians, most of which were primary care, but now we have taken on urology, hospital medicine, hem-onc, surgeons, etc. So, I mean, we were mainly primary care and then branched out. Originally, when it started, each office kind of ran themselves, and they were a loose organization together. Well, when we really organized for real, then they started setting up physician-run committees, et cetera, and hierarchy to help make sure that everything's being done fair and evenly, which it wasn't necessarily being done that way before. The way people shared call, the way people distributed finances, all of that was happening differently at each clinic, and that wasn't necessarily fair for everybody. So that actually was great for them to band together and make it equitable within each practice. that everybody's kind of doing things similar ways. But then also they were able to combine some resources like the referral team and things like that to make it easier for each practice to run. So they already were kind of used to autonomous doctors who are have very strong opinions, and they learned that they kind of need to work with us rather than fight us, because if they fight us, then we just leave. And so I think that foundation, I think they see themselves as a hospital-run, hospital-organized association rather than a hospital-owned organization. And I think that makes a big difference. I did ask my CEO, my Murray Regional Medical Group CEO, before the conference, because I knew it was going to come up, what made him decide to go. He went to a DPC summit, October, I think, of 2015. And he and my regional director went to this summit, and they came back and they started brainstorming, who should we have do this? What should we do? And I asked him, I said, what made you do that? And he said, ultimately, kind of what I said in my talk, he said, well, I'm looking at our bottom line, and some clinics aren't making money, and I was trying to figure out how do we make those clinics profitable? What is the issue? And he said the issue is lots and lots of staff members. And he said, well, how do we cut down on staff members when you need that many staff members to be able to file insurance? Well, what if you don't file insurance? Then you probably don't need that many staff members. And therefore, it led him to direct primary care by not filing insurance. Because even some of the concierge folks, I mean, they still file insurance. They still need the FTEs. And so then he went to the conference, heard about it. We affiliated with Dr. Forrest to learn more about how to do this. And I flew out there with my regional director to Dr. Forrest and did his weekday seminar, and got started.
Great. Well, this is really a remarkable story. And as I said early on before you started presenting, to my knowledge, you are the first one. This is the first hospital-sponsored model that has been presented in one of our summits. I'm aware of a few others in the country. There's, I'm sure, more than I know of, but you're a pretty rare breed, and I am hopeful that other hospital administrators and medical group leaders will get to hear your presentation and perhaps be inspired to try to do this from my own way of thinking. And the reason that the FMEC has been very supportive from the beginning is we think that primary care, family medicine, is the leading edge of creating a tipping point in our U.S. healthcare system. And if we can get the provider organizations behind direct primary care, I realize there will always be, and I want there to be, people who are independent and doing their own business model. But I think also if we're able to grow the primary care base across the country, following in your lead, this would be a good thing for our communities. It would be a good thing for America.
I totally agree, and I would be happy to talk with anyone who has more questions or present more data and more information and how my practice changes in the next year. I just crossed a year threshold, and we've done very well. We are now 470 members strong, and the next step that we're doing is we're actually approaching my hospital to offer my practice as well as maybe a higher deductible plan as an option for the hospital employees. My hospital has about 2,700 employees who need health care, and why would they pay someone else if they can pay themselves and save costs? So we're working to present to them the cost savings that I can afford by actually taking care of people in a timely fashion, and why they should offer this to their own employees. And so that is the next step we're doing in the next couple months.
Awesome next step. So I'd also like to say to the listeners, Dr. Gannon is very interested in having an opportunity to present her experience and her model locally. She's especially interested in talking to medical students and to residents about this model. So if folks are interested in having her come to their site as a speaker, she would be very interested in talking with them. Is that a fair statement, Dr. Gannon?
Yes, I enjoy teaching. It is definitely one of my passions, and sharing my story is something that I would love to do.
Awesome. So thank you very much, Dr. Gannon. I appreciate your presentation, and we'll bring things to a close here.
Thank you very much.